Get to the bit that often the audience likes best, and this is the young guys, the early to mid-career researchers. I'm very grateful to all of you for coming along. Some at relatively short notice, so I'm particularly grateful for that. And I'm just going to introduce you all, but they're going to do most of the talking, as are you. So naturally there's one mic here for you. Where's the other mic? Have you've all got mics? You're all mic'd? So there must be a second mic, good. So you'll run around with that later, will you? Great. So we've got Cassandra and Nadja who'll be running around, and you're allowed to ask whatever you like. But let me introduce our panel first. Dr. Mary Ann Anderson, thank you, is Associate Professor actually, so I'm sorry, my notes here aren't right, is a practicing clinical haematologist over the last 10 years, currently both at the Royal Melbourne and Peter Mac Cancer Centre. She's the foundation member of CAR-T Group, which I'm sure you all know is a very revolutionary therapy at around the world, and she is a foundation member of the CAR-T Consultant Group at Peter Mac, and joined at the inception of the unit at 2019. Marianne got her PhD from the University of Melbourne in 2017, and she undertook extensive clinical and laboratory studies of a novel approach to treating B-cell malignancies by harnessing apoptotic cell death. I don't know if that was me, don't know what that was. With an agent now known as venetoclax. Isn't that the one that got all the money? Or the rehire, like 263 million or something? It's a lot of money. But anyway, a revolutionary therapy. The sort of money which we all wish we could have in research. Since completion of her PhD, Dr. Anderson has continued her studies into mechanisms regarding B-cell malignancies and how they evade targeted agents to develop therapeutic resistance. Then Dr. Abby Douglas, Abby, pop your hand up there, is an infectious diseases physician working at the Peter Mac as well. We've got a slight Peter Mac emphasis here, and Austin Health. And a postdoctoral clinician researcher at Melbourne University and the National Centre for Infections in Cancer at Peter Mac. Her clinical expertise and research centres around infections in the immunocompromised host. She's an NHMRC Emerging Leadership Fellow and the clinical trials lead of the Australian and New Zealand Mycology Interest Group, and she sits on national and international steering committees, and also as a mum of 2 young children and a key advocate for women in science. And I have to say that all the women and the one man here were very keen to come because they want to advocate for young clinician scientists and women in science. Now, Katherine, the last two I have some disclosures. Katherine is was my PhD student long ago, and we work very closely together. She's a very successful clinician-scientist fellow and epilepsy team leader at the Murdoch Children's Research Institute. So she is a paediatric neurologist and epileptologist, which is what I am. I always say if you can say it, you are one, which the parents appreciate. And she works at the Royal Children's Hospital. And her research is very much focused on improving outcomes for children and specifically some very impressive projects on infants with epilepsy. And she has NHMRC support and MRFF support. Now, if you think that's a conflict of interest, the young man in the audience is an even greater conflict of interest. He helped me found this program. He's my son, and he... it was like, hello, so this is the 9th year. So 9 years ago, I was chair of the mentorship committee for the Australian Academy of Health and Medical Sciences, and we had our flagship program that I mentioned at the beginning of today, which was for professors and junior and senior associate professors. And he said, oh, Mum, you're getting him too old. You need to get him young. And so when he was a final year medical student at Monash, he and I put together first one of these Life as a Clinician-Scientist symposia, which is now around the country. Now, he's only half here because he hasn't got his PhD yet, which I have given him a suitably difficult time about. He's a Haematology Registrar at the Peter Mac, but I thought it would be good for him to come and talk to you about how you can do it differently. And what he's done differently is he got his FRACP exam and then promptly went on a Fulbright to Harvard and did a Master of Public Health, and then managed to talk his way into a postdoctoral research fellowship at Harvard and has been there 18 months and has now come back with 2 more years of haematology to do. But he's worked with a very incredible group called Portal, Program on Regulation, Therapeutics and Law. So it's medical people, ethicists, lawyers, a whole lot of, and they're looking at drug regulation and also associated with Brigham and Women's at Harvard, and his leader is a guy called Professor Aaron Kesselheim, and he's been publishing a lot for someone without a PhD. Anyway, how's that for the worst introduction your mother could give you? So I think the next... Oh yes, so now we move on to the session, and this is not advancing for some reason. What am I doing wrong? Oh, and now it's gone too far. There we are. So now we're up for discussion. So could we have our microphone people up where people can see you? And I think, actually, I just thought I'd actually let you all talk for a few minutes about yourselves. I guess I want you to talk about... Should I take some? Why you've chosen this career path? Why be a clinician scientist? So we might start with you, Marianne.
Yeah, so medicine's a very rewarding job, and I love it. I wouldn't do anything else. But you do get to a certain point in your career where there are only so many presentations and only so many options for managing patients. And there comes a time in many clinical careers, my own included, where every day can start to feel the same. And it's been, for me personally, a really important thing to have the laboratory or my research to go to, because in research, every day is different. In research, you have the possibility of being the first person ever to know something. And there's a level of excitement and newness and difference that I think really nicely complements a medical career. And, you know, the two together for me make it worthwhile. And I think doing one in isolation for me would not be the right balance, but together I get that mix of discovery and excitement, plus the reward of seeing patients and meaningfully changing people's lives as a clinician.
So, I mean, some of the motivations were fairly obvious in that I already was interested in this as a medical student, but and many of them are akin to what Marianne talked about. But I think for me, it's a lot about thinking about problem solving, about trying to make things better, seeing clinical problem and figuring out. And also, Professor Loy talked a lot about as well, where you see a clinical problem and then you try and work out, using your research cap, how you can solve it. And really that the people who aren't clinicians don't necessarily think about the world in that way or have the skill set to ask and answer those questions. And a particular interest and passion of mine is trying to work out and look through the data and look through the, sort of the epidemiology and the biostatistics of the data to work out what is clinically practice changing, what is clinically impactful, what is clinically meaningful, and that kind of scientific question of what is the truth but applied to clinical questions. So often studies are presented or data is presented in a way that is kind of has the conclusion in mind, and a lot of my passion for these types of questions is trying to work out, does this study really show what the conclusion says it shows? Do these data really advocate for a change in practice? And my research is kind of really far down the applied end of things, of looking at both clinical questions and kind of bigger system and policy questions around drugs and drug regulation. And I think that similarly the theme there is that having a clinical understanding helps me to think about and to answer those questions and to know the importance of those questions. And so I saw that, Shireen was talking about it, seeing it with scientists, but I also see it with policy people or lawyers that I work with, where you sit around a table having a discussion about making policy or law, and as a clinician, becomes apparent very quickly that having the clinical perspective as well as the research perspective is essential to answering some of those questions.
Thanks, Ed. I'm an ID physician by training, and I would argue that my clinical work is extremely broad and challenging and interesting, and every day is different in ID, so I'll plug for ID. That you can see any type of patient from anywhere in the world, any presentation, anything could possibly be infection, and you do get asked to consult on almost anything. So that's, I find my clinical work, incredibly rewarding, but very similar to what has been said before. It takes, I think, in many ways, a clinician's view of the gaps. What are the gaps when we're managing patients? What don't we know? What should we know? What can we do better? I also think that I'm, at heart, one, quite creative and arty, and two, a nerd. And so I love the creativity of research, dreaming, what can we do better? How are we going to do it? But also the real nerdy side of, getting back to stats and maths and, that kind of stuff as well. And also, clinical work, you do collaborate and you work in a hospital with different specialties and whatnot. But as far as the more bigger picture, working with people from, all around the world, meeting people and big thinkers, the research really gives that kind of side of my social and mental side of it. That's real stimulation.
Thanks, Abby. I think probably some similar themes, and I guess I would say my clinical experience probably parallels yours in that each day is also quite different. And I think in some ways I sort of fell into this through a sort of series of, fortuitous events in terms of being a clinician-scientist. But I think I don't like not knowing things, and I think I ended up being drawn to some of the more difficult clinical problems and some of the more severely affected children that we really didn't have solutions for, and I wanted to know why they had the problems they had and what we could do differently. And I think that even though I was very drawn to that in a clinical setting, I would have found it extremely difficult to have a career where I solely worked clinically in that sense and didn't contribute to changing outcomes for that group of patients. And so I think, that then sort of realised that having the science component too really helps the need for intellectual stimulation. You're doing some really interesting things. Being the first person to know something is a very cool feeling. And you get to work with some fabulous people like Ingrid, who have really completely changed the game, and working with inspiring people like that is wonderful. I love the broad collaborations that you can have, and I think someone mentioned that at the clinician you can almost be the linchpin of something, and you can have a rough working knowledge, or very superficial knowledge, I guess, of a lot of things, but dip your toe in the water of lots of things by virtue of the collaborations that you can have, and that's very rewarding too.
Right, over to you now, everyone. What questions have you got, or what would you like to probe? We have the mic. Yeah, we've got one there and one here.
This is a bit of a general question, but how do you distinguish between a really good research paper versus something that is maybe not as good?
You'd like to take that?
I think Ed might be
Are your mics working? Just see.
I don't know if it is. I think that was what was causing the feedback before, so I think that's why we've got these. Okay. So I think I sort of prompted that question, not to be the man who answers the first question and the second question, but I think a lot of it is context. So in oncology, haematology, for example, you often have to know the context that the paper comes about in. What is the data that came before, say? What is the true current standard of care? What are the pros and cons of that? And then the next part, so context would be the first part, the second part would be study design. Could this study, when it was designed right in the first place, actually answer the question? The way it's executed, has it been executed to answer the question? And then the results you get, how was the study carried out? Did the results give you a useful answer to the question or not? Which is a sort of fairly general answer to a general question. But I think context, methods, and results would be how I'd think about it at a general level. And then subspecialty-wise, I think it's different for different subspecialties.
You want to get Abby to have a go at that one too?
Sure. I think Ingrid's answer was great. I guess, you know, there definitely are different types of bias that you really have to look for in studies, you know, publication bias, selection bias. You know, there's lots of ways that studies can look good on face value and then maybe not be so much when you dig deeper. Because you've got to look, I think selection and the target group are you studying a representative group of what you'd apply to the clinic? Oftentimes studies get so niche, and when you look at, they started with 50,000 people screened and they got down to 500 people into the study, you have to wonder, what happened? Why? You know, how on earth can you get that far down the attrition pathway? So how would you actually put that into the clinic? One of the big problems with clinical research is, you know, we study the perfect patient without comorbidities, not old, you know, and these kind of things, and then we try to apply things to an 80-year-old with 5 different comorbidities. So I think we do have to look at applicability is a big one. I'm sure there are many other things that I could think of later, but there's some really good papers about study interpretation that we can show you.
Great.
Thanks for all your time today. A question as a clinician-scientist for all of you. I think inherently pursuing this pathway, we would have some increased amounts of curiosity about the world compared to a lot of other people. Say you have 2 interests, one in the research arena which is not entirely related to what you practice clinically. Do you think that's still possible to balance, or is it better to line up your research with what you practice clinically?
Yeah, I mean, I'm coming from a biased position, so what I research in the laboratory is directly related to what I do in the clinic. That has some advantages because there are multiple synergies that you can find. So I develop clinically relevant questions in the clinic, I can answer them in the lab, I can test hypotheses from the lab in my clinical practice. So there are synergies that you can achieve from having a research and clinical career that go hand in hand. But it is not necessarily the case, and I do have colleagues, one springs to mind who's a world expert in zebrafish. And you know, there are certainly lessons that we learn from zebrafish that we can take into haematology practice, but that colleague is, you know, a lymphoma expert, practices in lymphoma, but his research interest is much more basic. And you know, there are skills across both that can enhance each career, but they're not necessarily as directly linked as mine. Both are perfectly fine.
Yeah, I would definitely mirror what Marianne said. I think one of the really key advantages and I think we find it day to day, is that if we are running research where we are basically working with the patients and able to recruit, you know, directly from our practices, that's a major advantage. But equally, there are some people who are more experts in a type of technique or a type of research. For instance, they are good at health services, translational, kind of looking at how do we get clinical trial stuff into the real world and make it work. So it's more about, you have that skill set of looking at getting processes working in the clinic, or you're an AI expert, or you've got really good epidemiology skills that can be applied to, you know, hepatitis could be applied to lymphoma. So it's more of a skill set that you bring rather than a one disease specialty kind of thing. So you can make it work like that, and in some ways, if you have a skill set like that, you can actually be more, you know, able to collaborate with many different units and different teams. So that's one way to do it.
Yeah, I think there's an advantage in finding your niche, whatever that is, in clinical or research stuff. And if you want to do both in a public hospital in Australia, for example, it's particularly advantageous to do that, to actually get a role. What do you bring that is different to others? And sometimes what can you bring that actually crosses specialties as well, either on the clinical or research side, because there's more and more team science having an impact. Often relies on working with lots of people. So you don't necessarily need to do exactly the same thing, but having a niche is useful. And then I think also thinking about the practicalities of how are you actually going to get a salary to support yourself. You know, there are people who do research, I don't know, in a sort of international public health kind of field, for example, but they want to live in Australia and they need some money to practice, and so maybe you do a day a week as something that's not directly related. There's lots of factors in your life that might line up to make the decisions that you make.
Thank you. My questions probably closely follows what you were just talking about, sort of crossing the different specialties or different disciplines. One of the things that happens in clinical practice that I'm finding is increasingly you're so focused on becoming good at your specialty that the collaboration tends to go down. I mean, there is collaboration, but clinically there's far more collaboration than in research. I'm finding that in research, I'm finding it a little bit difficult to break the boundaries between different specialties. And this might be coming from maybe not so much medical specialty, but from a dental specialty background. So I'm an oral medicine registrar at the hospital. So crossing that barrier between, let's say in oral cancer, crossing that sort of barrier between dentists and medical doctors, I find that quite difficult, or to find roles or to find teams to sort of be part of to cross in clinical practice or in research. How do you sort of navigate that, or are there opportunities to sort of go and sort of speak to different people to see if more paths can be made for something along those lines?
It's a very interesting question, Marianne.
Yeah, so my personal view on this is, and maybe it's my nerd factor, but
what you sort of described sounds like silly politics, right? I mean, these are artificial boundaries and they shouldn't really pertain to interesting and important scientific questions. So it really doesn't matter what your background is, whether you've got a PhD or not, whether you're a dentist or a nurse or an allied health professional or a doctor. Like, it shouldn't matter. If you've got the interest and the drive and the skill set, you should work together, because we all benefit if we can work together. So, I've been around long enough to realise that politics and these kind of sometimes quite petty things can get in the way. But I would encourage you to keep going, because you will find people who want to collaborate, want to work on the right question. I think it circles back to what Shireen was saying. You've got to find a team of people, you've got to work in a place where the science really is paramount and you're given the support you need and the collaboration you need to answer the question. And not every place will be the right fit, but there are teams out there where you do get multidisciplinary collaboration, and really profound synergies come from that.
So yeah, my group in the US was very interdisciplinary, and so that meant that when someone had a haematology question, they would email me, and if I had a patent law question, I'd email the patent lawyer, or an admin law question, I'd email the admin lawyer. But really the biggest lesson is personal relationships. So trying to have coffee or lunch with someone, trying to become friends with someone when you don't need their advice, so that when you do need their advice, that you can call them, and likewise that you give your advice freely to other people, so that when you have advice in return, you can offer it. And some of it sort of comes a bit back to what Miriam was saying about authorship and being generous, generous in giving your advice when you can give advice, and generous in giving people authorship when they've given you advice. But I think really it comes back to personal relationships, and the more you can either use your personal relationships, meet with people, get coffee with people, and your boss's personal relationships, saying, who do you know in this field that could help, I think breaks down those barriers.
Yes, at the back up there. Sorry, that's a bit of a run.
Thank you very much. Okay, so I want to ask about what are the biggest problems did you face during research? Is it the funding, ethics, collaborations, clinical trials, or the writing process, or other things? Yeah, thank you.
Katherine. I think there are a lot of challenges. There's definitely things like security of funding is an issue that we all face, and things like writing grants is something that no one really likes. There are difficult aspects to the research that you have to cop if you want the fun. I think one of the things that is difficult and I guess varies at different stages in your life is the juggle with everything going on in your life, both in your working life and outside of, and times where you might not be able to do as much as you want to do in any one area, and times where you feel like you've taken on so much you're actually making no headway in any of that. And so I guess knowing what to say yes to get the opportunities, but also learning when to say no to something. And I think that's actually something that's very hard early in your career, because you want to take as many opportunities as you can, but you also want to try to get to a point where you're not about to explode because of so many things you need to do.
Abby?
Thanks. I mirror or echo everything that Katherine has said. I think, on the question of ethics, I think things are getting harder and harder every day, to be honest, with sponsorship, ethics, governance, the lens on research ethics and that is getting harder and more tight in Australia, and does mean that there is a time that bleeds out, and you just find that something you thought was going to get started in 6 months takes 18 months, and it is a bit of a bit of dismay there, really. But we work in the system and we just have to work with it, and I guess you kind of learn lessons as you go along as to how to get the most efficient course, and also anticipate problems before they come up so that you don't have the review process and the things that drag on. Having a good team who have experience with navigating the system really helps. But I definitely agree with Katherine. I think the biggest challenge is, I guess, particularly as a woman and a mother, but in anyone's life there's lots of things that people have to juggle, is trying to just feel like you're doing a great job of what you're doing at work, great job at home, paying enough attention to all the balls that are up in the air and making sure you don't drop one. And yeah, really working out how much is enough and how much is too much. One thing with research is that, particularly as a clinician, because you want to be collaborative and be involved, is that most of that stuff is free. You don't get paid for that stuff, and in fact, realistically, a lot of clinicians get the money from doing clinical work. Some of us have grant support that gives us some kind of salary, but oftentimes it's kind of the project's funded, not necessarily you so much. So it is something that I'm still learning, to be perfectly honest, and I think it's not like we're in America with tenure and things like that. That tends to be really helpful, that you don't have to worry about the salary side of it. So yeah, I think those are the key challenges for me.
Marianne?
Yeah, I mean, I would reiterate the things that have been said. Personally, I think, people embarking on a clinical research career, you need to go in with your eyes open. It isn't easy. And I think it's been said a number of times that getting that balance right, whatever balance looks like for you, between your clinical work and your research work, it can be really challenging, and I think the answer is different for everybody. Ethics can be a struggle. There are lots of challenges, but I think all of them can be overcome if you're passionate and driven, and this is something that you really believe in. And I think it comes back to choosing a path that you're passionate about, because you will find the drive to keep pushing through and make it work if you are passionate about your projects.
Yeah, I echo what's been said totally, but I mean, research needs a lot of resilience. Some people hate that word. I think it's a very real word. Your grants, you put a lot of work into them, they don't get up. You write a paper, you send it to the journal that you think it's perfect for, a really good journal, doesn't get up. And the skill is in knowing where to target that paper. You go for the highest likely, but not the unlikely, because then your poor student goes down 10 different journals and it's totally demoralising. So there's a lot of skill in getting the right grant, there's a lot of skill in getting the paper in the right journal. And that is a big roller coaster, and you have to really take the wins and you have to go, wow, we got that grant, isn't that wonderful? And if Katherine writes her grant and she gets it, and I'm in it, and so you're a co-PI, principal investigator, that is fantastic. If I get a grant, it's fantastic. You've got to take the wins, and you've also got to dust yourself off, get up and get on with the next attempt. So it's not like we love this career, but it has got lots of wrinkles. Ethics is but one of them. Funding is huge. Everyone's talked about funding their salary. What we haven't talked about is funding our team. And Sam and I have a team of 10 research assistants, a whole lot of PhD students, a whole lot of bioinformaticians, all sorts of people. And what do I lie in bed at work at night about? Apart from the patients, I worry about how am I going to fund their salaries. So there are lots of different pools and tensions. But, you know, the outcomes are exciting, which is what I hope you're getting. Now, some more questions? So while you're thinking, I'm going to ask Eddie, you've done it backwards. Why bother going to the US?
So yes, I did it all quite backwards. I wanted to be an endocrinologist and was going to have a career in obesity and diabetes and public health that fit all nicely together. And then I fell in love with haematology and had to sort of reconsider what I wanted to do. And so I went to do the Masters of Public Health knowing that I still very much believed in public health and the ideas of public health, but also that I now wanted to be a haematologist, and just sort of had this faith that I'd figure it out and make it work. And as it turns out, in one of my classes, I read a paper by the guy who would end up being my boss and mentor, but I approached a few different research groups, and he was one of them. I ended up doing a little winter project with him, and then I ended up applying for and getting the postdoc to do with him. So I think it sort of all, at the end, sort of came out like a nice linear or nice clear path, but very much was a sort of iterative process where along the way I changed as opportunities came up. In terms of why the US, I was very fortunate. I had lots of opportunities that came my way in terms of collaborations, meetings. I could just hop on a plane and go to Washington DC for the day, or hop on a plane and go to wherever the meeting was. And a really great group that I got to work with. And I think a lot of those opportunities perhaps came in part because of being in the US and again, sort of bi-directionally, I work a lot on the Food and Drug Administration and the US FDA's policy, because I think that drives how clinical trials are run all over the world. And so it was sort of US-centric, but very internationally applicable. So I think is the answer to why the US.
And do you think you'll do a PhD?
Well, leading question, but probably at some point we'll finish my training and finish my clinical training and cross that bridge. But I hope so. I think a point that you frequently make is that a PhD, and I think this is true of my postdoc to some extent, I think it teaches you to think differently. It teaches you to think about questions differently, about how to answer questions differently, and I don't think we necessarily learn that in medical school or in physician training. We're a bit of a biased bunch of physicians, but in medical training generally, I don't think people necessarily think about how to answer scientific questions.
So Eddie has not heard Sam's talk from this morning, just so you know, that came out independently. I'd like to ask all the women present about having children. How do you make it work? How does that impact on your life? We heard Shireen's view that you have to work full time. I don't know that that's my view. I'm interested in what you think about it, and, you know, is it worth the trouble? All that stuff.
Is it worth the trouble? Yes, most of the time. I have two children, they're 8 and 5. They're both now at school, which is great because it's only one drop off and pick up, and definitely I agree that things do get a bit easier as they get older and more independent, although to some degree still in the trenches. I think one important, well, the first important thing, I guess, is do you want to have children? But if you've decided that that's the case, then an important consideration is when. And I think that when will vary for your own personal reasons, but also your career reasons. And a big factor is how onerous is the clinical training that you're doing. You know, if you've got long working hours or all over the shop working hours, lots of on-call and things like that, that's a difficult time to have kids because work is so full on and time consuming. Equally, if you're in a profession, in a specialty where part-time work is not the norm, I don't know, for example, a lot of the surgical jobs, there's very few part-time specialties. In paediatrics, there's a lot more, and so we're fortunate in that respect. But if there isn't the opportunity to either work part-time or take some time out and get back into things, then during the clinical training is actually very difficult. I made the decision to have kids after my clinical training and during my PhD, and the increased flexibility there worked very well for me, but different people will make different decisions. But I think how busy is your clinical training is actually a really important factor.
Thanks, Katherine. I 100% agree with your comments, and in fact we probably had a fairly similar kind of path in the sense that I 100% agree. Basically, infectious diseases training is, you know, very full on, long hours, research projects, Those things are often, and it's such a formative time for your clinical experience, your knowledge really is the time when you really need to knuckle down and learn. And doing those projects, actually, there are certain things that you don't realise how important they are until later. So one thing was that I worked really hard in medical school and got an honours, which I didn't realise later was actually quite important for when I got my Uni of Melbourne scholarship, that they actually cared that I had an honours. So, you know, that's one thing. Then getting a couple of research projects done during my junior medical, junior medical work really was important to then trying to get jobs and PhD scholarships and things like that. So I think that was, you know, your advanced training time is a challenging time if you're doing certain specialties. I think it was a good choice for me to have family during PhD because of the flexibility. That's not to say that you do sometimes have that perception that just because you're flexible means you have a lot of time, and that's not true. You still have a lot of work to do. It's just flexible when you do the work. So sometimes you get a bit of kickback being like, oh, but you don't have to be there at this time. It's like, well, I still have to get the work done. It's just not, you know, I don't have to be specifically somewhere at a certain time. I definitely think that it depends on how many children, if you want children, how many you want. Biology is a big thing, and so if you want to have more than one child, you know, you shouldn't wait till late, because I know lots of people who've had trouble, and it's one of those things that's easy in retrospect to see that was going to be a problem. But, you know, so it's got to be what's your priority.
Yeah. So I think that anyone who says that there's one way to do it is probably misleading you. And my only counsel for people is to do what's right for you. And if that's having a baby in medical school or not at all, or having a baby when you're 40 and you finished your PhD and you've got a consulting job, there's no right answer. And whether you want to work part-time or full-time, I actually think that you can make, and what you should do is make it work for you. Okay, so, you know, we're in a very fortunate position as clinicians and researchers. There are so many opportunities, and you can build the career that you want, that works for you around the family that you want to have. And I think Shireen's talk was masterful, but I do disagree that you have to work full-time. I think you can make it work part-time if that's right for you. If it's not right for you, it's also great to work full-time. I don't have the answer for you guys, because I think you've got to figure it out for yourself. But I would encourage you to do what's right for you in your personal life, and try and give you some confidence that if you're driven and intelligent, which I'm sure you all are, you'll figure it out in your professional life.
Okay, thanks.
Thank you all for being here. It's a general question for anyone. After you've done the research project or your PhD, how was it going back to clinical work? Was the training program supportive, the clinic or the hospital you went back to supportive, and how did you manage going back into the clinical world?
I'll start. So For me, I did clinical work all the way through my PhD. So it was really a very smooth, in fact, I would say it was a non-transition. One of the things, the morals one of the things, I guess my personal gripe is pathways, career pathways for clinician scientists, because I think that at the moment, a lot of the training that many of us do is quite disjointed. So you do your clinical training, then you go off and sit in a lab for 3 years, and then you come back and you try and figure out a right balance. And I think that there is a increasing recognition amongst universities and hospitals that we need to have career pathways that develop both careers simultaneously. And I think, you know, with the MD, PhD type programs that are now starting to come online, we're starting to see a shift towards enabling people to progress both careers simultaneously. I don't think we're there yet, but I think we're moving towards that.
Yeah, I've just done that about a month ago. So I was actually just talking to Marianne. The question I wanted to ask Shireen was, because she said she was in Belgium for 10 years. I don't know if she speaks Flemish or French, but whether she had done clinical work during that period. But what I was talking with Marianne before about was that in research or academic land, you have to have a lot of intrinsic motivation. You've got to decide how much reading is enough reading, how much revising is enough revising when you revise a paper, how much time on each project, how many projects, etc. Clinical work is much more, it all gets dumped in your lap, and if you don't, you know, get the water out of the boat, you're going to sink. So there's much less intrinsic motivation that's required. So I think that's something that I haven't heard talked about that much, that certainly we were both talking about before as a big factor.
Was it hard to go back to the clinical?
Well, I mean, a little bit. I actually found it the other way harder in terms of the freedom is beautiful, that you get up in the morning and it's 8 o'clock on a Monday morning and you don't have a ward round to do. You just have a journal article to read or so the freedom is very freeing, but the lack of direction, you know, like my boss expected me to come with most of, in fact, if not all, most of my ideas for projects came from me, I wasn't sort of handed them. And that's very different to, especially as a non-consultant clinically, a lot of the time you're just sort of doing the job. Yeah, exactly. So yeah.
Yeah, I think I echo what Marianne said. I actually think if you want to be a clinician at the end of the day, still, I think you do really need to keep your skin in the game a bit, because I guess it depends on the specialty you want to do. But if it's a skill-based specialty, particularly surgery, you just got to keep operating because it's about a skill that you need to keep maintaining. Also, your brain is a muscle, and the kind of clinical acumen and skill also, I think from my perspective, particularly as an ID physician, and things just move so fast. There's so many things happening, trying to keep up with COVID, you know, learning all these new emerging conditions. If you're out of the game, it's hard to get back in the game. So I think you can do part-time PhD, or you can do a certain amount of work allowed in your full-time, but I think it also just helps to keep the drive. You know, why am I doing what I'm doing? Oh, here I am again seeing a patient. You know, there are reasons I'm doing. It's a motivator as well. Keeps your brain active in different ways, keeps you stimulated in different ways, keeps some money coming in, all these things.
Yeah, definitely, I agree with that. I did a little bit of clinical work during my PhD, and so similar experience. I think one of the difficulties of that time coming back is it's a time of big change and a time where you might start doing more clinical work, or you might not, but you might. But you might also want to keep up the research stuff, and so you're increasingly busy. When you come back into the clinical work, you're coming back with a PhD, and if it's in something that's vaguely clinical, you're going to come back as an expert in an area and bring something to your department that they haven't had yet. And people will want that, and you will get a lot of work, and you quickly find that that's very big and you need to work out how to contain things. It's also often a time that can be a little bit uncertain in your research career because you're looking for salary funding, project funding and things, so you might be quite busy writing grants. So it can be challenging from that point of view, but it's also a really, I think, exciting time where you've got emerging independence and you're starting to use your research skills for clinical impact that you can see directly. And so I think that offsets the challenges.
Another question? Yeah, back there, Andrew.
Hi. So deep learning has been making quite a buzz recently. So with large language models and for image and audio processing, what do you think the effects of new AI technologies are going to be on, number one, clinical practice, and number two, the research process? And is this a promising technology, or is this something that's not going to have much utility long term?
Who wants that easy one?
Marianne, go. I don't know anything about AI. I'm just going to put it out there. I discovered ChatGPT at a dinner party a few weeks ago and we had a bit of fun with it. So that's the extent of my knowledge. What I would say is that, you know, as a haematologist, nobody is ever going to want a computer to tell them that they've got cancer. That you can't get rid of doctors and that relationship with the patient, because I think it is more than just X, Y, and Z symptoms equals A, B, and C treatments. There is a relationship and a therapeutic relationship which is priceless. From a science perspective, managing big data and managing, you know, some of these experiments, the single cell experiments, is just, you know, enormous amounts of data that a human being can't physically deal with. So I think that using these technologies to help us to make sense of big data will be important, but I don't think any of us are going to be out of a job. Maybe I'm wrong.
I think that's an easy thing to agree with, Marianne, about that none of us will be out of a job. I think both in science and medicine we'll see some impacts. It's hard to know how fast that will happen, and that's partly because of our whether or not we're happy to trust the AI, and that's at a clinical level, whether we trust it, and at a research level. There's been a lot of buzz recently around some papers that were published with very clear stuff from ChatGPT that managed to make it through editor, peer reviewer, copy editor, and still get published. You know, it says, "Thank you for asking me to help you write an introduction," and it's published in the introduction of the paper. So it certainly will shake up that side of science and medical publishing, and you know, I think certainly I don't go anywhere near ChatGPT for anything that is going to get published, because I think that will evolve, and I'm not sure how it will evolve, but I'm sure it will become very important in that space. And in terms of medicine, a lot of the way that it's applied is about the regulatory environments that we're in, and what different AI is allowed to do in clinical settings, and about building up clinicians' trust with that. So it's hard to know how fast clinicians will adopt the technologies, but I'm sure that the technologies will absolutely come.
Agree with everything that's been said. I think that, you know, like any new technology, we can't just ignore it and think it'll go away. We do have to embrace the fact that these things are coming, and they're probably going to be here to stay, and the challenges will be around ethics and how it's used safely and well. And, you know, from a diagnostic perspective, just like Marianne said about the patient relationship with telling someone of bad news or whatnot, I think diagnostically you can't really replace the thinking process and the examination and those things that come with clinical medicine. I think where it's going to be quite helpful is there are a lot of inefficiencies in medicine. You know, one pathology service to another, to a radiology, to, you know, things don't talk. And I think that what probably is really helpful will be trying to harness the data from different data sets and having it process and identify things that we didn't necessarily realise before from multiple information sources. That I think is going to be quite powerful, and we will use that to our benefit in the future.
Yeah, and I think it probably will help to amplify expertise that's out there. So I guess to give an example, one of my colleagues has just finished a PhD looking at tiny brain malformations that cause seizures, and you can remove the tiny area and you fix their epilepsy. It's a complete game changer. But finding those things on a scan are very difficult. If you want someone to find it, go to her and she will look at the scan and find it. But most people can't do that. And so part of her study is actually to say, okay, well, if I was going to design can I design a model with all the knowledge that I have? Can I design an AI model and test it that would do something similar to what my brain is doing and allow it to be used by lots of people? And I think those examples could really be extrapolated for benefit around the world, because we can't all be expert in every area. But I think whatever we develop, we need to be asking the right questions and we need to be using the right data. And I guess our field also is, it's really important. There's a lot of people doing big data things on data from medical records, which are often very poorly documented. You put something in that's rubbish, you'll get out something that's completely useless. And so you need to be asking the right question and using the right data. And I think also there's a bit of a sort of maybe a tendency to say, well, these kind of things are very good for pattern recognition, and sure they are, but also I think we forget how good we are at pattern recognition too. And there's often things that you will pick up by seeing patients in clinic that are very hard to put your finger on exactly what you're noticing, but you're noticing something and a machine could never pick that up. So I think we can't forget that that is an advantage of being human and observant humans.
Yeah, that's a great series of answers. And I think AI is getting a magic about it that's really not earned as yet. I mean, I think there's no doubt with big data sets it can do things that none of us can do, but often the innovation is still the human mind that comes up with the idea that then uses those data sets. So don't be too seduced. One day maybe, but I think we're a fair way from it yet. And got to remember that it's the human brain that's really got us to where we've got. Yeah, thanks.
Hi, so my question is about the PhD. So the reasons and advantages and so on, why you chose to do a PhD program, because I'm an international student and part of our medical degree involves a thesis at the end. So when I talk to our doctors, they usually say you don't need a PhD to be a clinician-scientist. You can also just go into research without the PhD. So I wanted to ask, what were your reasons and what do you think are like advantages to do the PhD?
Relatively quick answers, Abby. Do you want to start?
Again, I think it's contextual. So it's kind of where do you want to work and what do you want to do at the end of the day. So if it is genuinely that in your country where you're from, and the PhD is not required to do the research. What I do know in Australia and in this country is that, particularly for career progression and funding, there is a kind of stepwise. It's usually you do your PhD, you're then a postdoc, you're an early career researcher, you're a mid-career, and so some of those funding opportunities really are only open to people who have done XYZ. So for instance, I'm about to apply for an early career MRFF grant that literally it's quite prescriptive that you have to do these things to get to this point. So I guess you can be a clinician researcher and you can still definitely do research and get funding from various angles, but it does open the box to opportunity. The PhD itself is obviously a good time opportunity to really explore, like what Shireen said about different techniques, different things, different skill sets, and what is your passion. So it gives you that time as well to do that.
Yeah, I mean, you don't have to do a PhD. You can have a very fulfilling career. You can do research without one. But The PhD is a period where you learn skills that I personally would not have obtained had I not done a PhD. It's a really privileged period of time where you can step back from other activities and learn. And there aren't too many opportunities in life to do that. I personally came out of it with a bunch of skills that there would never have been another opportunity to gain, and that I used to various degrees, and I use currently and will continue to use throughout my career.
I don't think I have anything more to add. I agree.
So I will say it again.
Well, I'd like to ask everyone to thank the panel with me. I think you've given us so many things to think about, and hopefully you'll put them into your plans about the future for you. So please join me with thanking the panel, and I'll get you to sit here just while I close up.